So may I now invite our next speaker, Professor Rohit SAXENA, to speak on the optical intervention for progressive myopia.
Thank you for the opportunity. We'll be changing gears and moving on to optical interventions, which are now fairly easily available. I do not have any conflict of interest. We know that the problem is pretty big, it's increasing. There is a role and importance of early intervention, and there are traditional as well as newer evolving opportunities and options to manage. So in this, I will be talking about the optical interventions, and my main emphasis is going to be the spectacles, which is more accepted, particularly in India at least, and that is the area which I personally have the maximum experience on. So can I have a pointer by any chance? Excuse me, pointer. So this is essentially showing you the concept or the thought behind the optical interventions that we have. That the first photograph is of an uncorrected myope. So the uncorrected myope, you can see that because of myopia, you have the image falling short of the retina. When you traditionally single vision glasses make it optimally corrected at the fovea, but as you move away, because a prolate shape of the back of the eye, on the mid periphery, you're going to have a hyperopic reflex or a hyperopic defocus of the image, which is, so the periphery is giving you a hyperopic defocus, and that is the concept on which optical interventions are based. So the thought is that this hyperopic defocus is responsible for the stimulus for axial length elongation and therefore the myopia progression. And the newer concept is now that while you have the optimal correction for distance in the center, the surround has an additional power that converts this hyperopic defocus to a myopic defocus, thereby reducing the stimulus for axial length elongation. So we have a lot of options. We'll quickly run through the ones that are available. These are the DIMMs. As I mentioned, I have no commercial interest in any of them. So this is the central clear. There is a honeycomb kind of a effect there of these lens sets, which are about 3.5 diopters add. They ensure that the periphery of the lens creates the myopic defocus. It's about 50% of the area of that lens in any given point that has the clear vision. So between these lens sets, you have the distance vision correction. So although we rarely tend to see too long from the edge of the lens, but if a child looks from the side, they will feel a little bit of a blur, and they usually would come back and move their head to see in that direction, but at least 50% of the light is still going to focus on the retina. So these are the DIMMs, or the diffuse induced multiple segments. The Stellest lenses or the SLR based lenses had a very slight difference. So they've talked about a volume of light in front of or a myopic defocus. So they have an increasing power from the nearer the center towards the periphery, because again, because of the prolate, the claim is that it's getting more and more steeper. So a standard 3.5 diopter add may not always give you a myopic defocus in the periphery, and therefore the powers increase. So this is the Stellest commercially available from SLR. Zeiss came out with a slightly different concept. They have these micro cylinder arrays. All of these, 50% of the lens in that part is corrected for distance, and 50% of the area has the add. These are cylinders. So the cylindrical annular refractive segments, they go all around on the lens, and they result wave differences inducing a blurred image in the peripheral retina, contributing to myopic control. So again, almost in all, there is about 7 to 9 millimeters. So they have two different glasses, the 7 mm and the 9 mm. So in rapid progressors, in younger children, you use the 7 mm. In older children, you'll use the 9 mm, so that have a little larger clear vision field, and of course the periphery is going to help you for that. This is a relatively new technology that has come up. Inadequate information is there, not too many large studies, but they work on a totally different concept. It's different from the one we talked about. It's essentially high contrast. So according to this concept, high contrast of screens, books is responsible for the myopic stimulus, and that is to be corrected by these dot lenses which control the contrast. So the aim is, again, they have these multiple small lenses here. The aim to reduce the contrast between adjacent cones. So the high contrast stimulus, which is believed to be responsible for the myopic progression, is corrected by these dot lenses. They do not cause a peripheral defocus. So their concept is different, and as I said, information and studies based effect of this technology is still kind of evolving. So just a quick head to head, these are the available studies. So a 2-year RCT showed about 50%. So most of these optical interventions are showing, give or take a bit, 50 to 55% efficacy in reducing refractive error progression, and about 55 to 60% in reducing the axial length elongation. So these are for the DIMS, this is for the Stellis or the Hort lenses. Again, approximately 55% reduction in the spherical equivalent reduction. Less data is available for the Care lenses. However, they are also doing nearly as well, although again there are no head-to-head randomized trials between the three, so it's difficult to do absolute comparison, but give or take they have an equal effect. The dot technology, again, very little data is available, but they also appear to work. So essentially, give or take a bit, there is nothing to choose between either. You can take a call on based on availability, on the acceptance, and of course other what the parents prefer. So there's no gross difference between the lenses. This is a kind of a head-to-head. We know that single vision lenses don't make a difference at all. Prismatic bifocals had an effect of about 40%, but again it was in a more subclass of children who had accommodative lags and esophoria. Progressive ad lenses, no really benefit. And then we have these 4 types of lenses where ranging between, as I said, 50 to 55% grossly you see the effect. This was our data, which is ongoing. It's an ongoing study. We've just completed a randomized head-to-head between the 3 types of optical lenses. But again, here in India, we saw the DIMS showing about 58% and Halls showing about 60%. So again, give or take a bit, depending upon your patient profile, the age group, you are going to get results somewhere between 50 to 60. So we know that these lenses are effective. They are causing a reduction in the axial length. Therefore, now they are increasingly becoming a possible option. Quick words about soft multifocals. Unfortunately, our experience in India is rather limited. In fact, the Me-Sight lenses were among the earliest FDA approved interventions for myopia control. Again, they work on the basic optical principles that the spectacles are based on. They were the earlier concept on which lenses were based, and they also have been shown to be effective. These are again the studies of the soft contact lenses showing a fairly good effect. At least up to 40% is evident as a reduction in the spherical equivalent increase. A new concept has come up with orthokeratology. Again, a lot of myopia treatment we have actually evolved just by chance. A lot of our understanding is coming just by chance. Orthokeratology has been around for a very, very long time. As I mentioned yesterday, it's the poor man's refractive surgery. You wear the contact lens overnight, and next morning you don't require any optical correction, and you can pass your day without wearing glasses. And over time, they realized that the orthokeratology also helps to reduce the rate of progression. There are you need to be wary whenever you're following up these children, because the corneal changes occur, the shape of the cornea changes, the epithelium piling up in the mid-periphery occurs. Therefore, your axial length, which should be the most important effect that you're looking at, may change. Of course, your refractive error does change. So if you're doing follow-up of a child, measure the refractive error and the axial length at the same time every time when you're doing the follow-up, and if possible, after a period of removal, so that the cornea comes back to its original shape. So unfortunately, the benefit has been found mainly in the first 2 years, and after it wanes off. So there is some bit of rebound that has been reported in orthokeratology. The studies show fairly good efficacy, again ranging between 30 to 50% depending upon different studies. But again, the effect is the same, like the lenses that we talked about. They create the piling up on the mid-periphery, and that is responsible for the plus add that is happening in the mid-periphery. So essentially, bringing all this together, there is nothing head-to-head comparing the various kind of spectacles. It's based on availability. Again, the choice between opticals and pharmacological in a country like India, where pharmacology is the drops are fairly cheap, they're extremely inexpensive. a lot of parents still would continue to prefer the pharmacological interventions, but optical interventions are increasingly becoming very, very popular. And while these designs appear to be effective and safe, longer studies are required. The safety, efficacy, and compliance appears to be the best for spectacles as compared to other modalities. But again, like I mentioned, for a country like ours, the major limitation remains the cost. Thank you very much for the opportunity.
We can take 1 to 2 questions.
So just like any treatment, so essentially I would first confirm that it's progressive childhood myopia. I would start with one of the treatments as my primary modality, unless child is very rapid progressor, but I would still continue to start with one of the intervention modalities, whatever, whether optical or pharmacological. As I mentioned, there's nothing head to head, one being better than the other. So depending upon the patient's willingness, compliance to put a drop every day at night for 2 years, which can be quite daunting, or the upfront investment in an optical lens, again that can be challenging for parents. So depending upon their preference, we'll start with one intervention modality. I'll see for 6 months and see for the effect of that intervention, and depending upon the response. So if there is a moderate response and the child is still progressing beyond 0.5 diopters, I would add a modality. If there is virtually no effect, maybe I'll follow up for a little bit and then think of adding a modality. So that's how I would prefer not to start on the first go with 2 modalities, because I don't know which is effective and by how much is it effective, so that I have my learnings for the future. Generally, in the initial period, I would see the patient 6 monthly, and 2 very key parameters you need to follow up. One is the refractive error change, and 2 is the axial length. So do a biometry also. All of us have a optical biometer, so just keep a follow up and you can see for change. So see for change, that's why I said we should know the rate at which the child was progressing prior to intervention. Suppose the child was progressing 0.75 diopters in the last 1 year. In this current 6 months, the child has only increased by 0.25 diopters, say. So I would assume that the reduction has been from 0.75 diopters a year to about 0.25. 0.5 over the year, and I would continue and see after 1 year. And if he's following after 1 year, I'll see for the, again, as I mentioned, not only the refractive error, but also the axial length. We have seen that there is a change in the lens power, so there is an anterior segment compensation because of atropine. So that is why one should use axial length as a better monitor for the impact of the intervention that you're giving, especially for a pharmacological intervention. And finally, of course, axial length is the thing that we're more worried about rather than just the spherical equivalent.
Yes, please.
Okay.
One more question.
Hello. Yeah. So, so I was interested in the comparison between the dim spectacles versus low-dose atropine, which is what we always a little concerned about. Not many head-to-head studies, but we did a small in-house study, and we found that actually the spectacle lenses had slightly better edge over atropine in the first year. But having said that, the first 6 months, atropine had a slightly better edge over the spectacles. Have you had any similar experiences? Is it a matter of compliance with the drug, or is it just, or do you have any experience with tachyphylaxis or something like that developing with the drug over a period of time?
As I mentioned, we observed that there was a little bit of lens power change that happens because of atropine. So the initial great result may be mildly because of the anterior segment compensation of atropine, and I believe that may be also responsible partly for the rebound that you see, but there is a real true effect of atropine that we know without doubt. Yes, anecdotally or two separately, the studies do show a slight edge of opticals over the pharmacological, but then these are 0.01. As we've discussed earlier also, the effect of various doses will be different in different races also, because of pigmentation, because of pupillary size, because of anterior segment compensation that is happening. We have heavily pigmented iris. We know the atropine gets absorbed and settles in the melanocytes in the iris and may have a slow release. So initially you may see less effect, but over time you'll see cumulative effect as the drug diffuses out. So there are a lot of things we're still learning about atropine. Possibly there may be, but then again, till the time we have a good randomized head-to-head comparison in different races, different age groups, it would be a difficult call to make.
Thank you.
Thank
Thank you, Rohit.